Morning class. So today we're going to be going over chapter 31, Orthopeadic Injuries. So apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Orthopedic trauma. Recognition and management of open fractures, closed fractures, dislocations, and amputations. Pathophysiology assessment and management of upper and lower extremity orthopedic trauma. Open fractures, closed fractures, dislocations, sprains, strains. Pelvic fractures, amputations, replantation. Medicine, apply fundamental knowledge to provide basic emergency care, transportation based on assessment findings for an acutely ill patient. Non-traumatic musculoskeletal disorders, anatomy, physiology, pathophysiology, assessment and management of non-traumatic fractures. Introduction. Musculoskeletal system provides form, upright posture, movement. A system also protects vital internal organs. Bones, muscles, tendons, cartilage, and ligaments are still at risk. Musculoskeletal injuries are among the most common reasons why patients seek medical attention. Often easily identified because of associated pain, swelling, and deformity. Often result in short or long-term disability. So 3 types of muscle: skeletal, smooth, and cardiac. So remember how many types of muscle there are and the different types of muscle there is. Cardiac muscle is only going to be found in the heart. It's a good way to know that. Skeletal muscle attaches to the bone and usually crosses at least one joint. Also called voluntary muscle, makes up the largest portion of the body's muscle mass. So we have a little picture here of skeletal muscle back near the calf. Okay. All skeletal muscles are supplied with arteries, veins, and nerves. Skeletal muscle tissue is directly attached to the bone by tendons. Extensions of the fascia that covers all skeletal muscle. Smooth muscle performs much of the automatic work of the body, contracts and relaxes to control the movement of the contents within the tubular structures. Cardiac muscle is specially adapted involuntary muscle with its own regulatory system. Skeleton gives us our recognizable human form, protects our vital organs, allows us to move, produces blood cells in the bone marrow, made up of approximately 206 bones. Okay, so your upper extremities, and then your lower extremities. Shoulder girdles can be up here, and then your pelvis. Skull protects the brain. The thoracic cage protects the heart, lungs, and great vessels. The pectoral girdle consists of 2 scapula and 2 clavicles, shoulder blades, and collarbone. Okay, so sternoclavicular joints can be right here, clavicle, humerus, shoulder joint, sternum here. Okay, the upper extremity extends from the shoulder to the fingertips, composed of the upper arm, the humerus, elbow and forearm, radius, and ulna. So the hand contains 3 sets of bones: wrist bones, carpals, hand bones, metacarpals, finger bones, phalanges. So this is how it's sectioned off. So the very end are going to be your phalanges. Kind of the middle part, like right in the center of your hand, are going to be your metacarpals, and then down below is going to be your carpals near your radius and ulna. The pelvis supports the body weight and protects the structures within the pelvis, the bladder, rectum, and female reproductive organs. The lower extremity consists of the bones of the thigh, leg, and foot, femur, thigh bone, femoral head, tibia and fibula, patella, and kneecap. So femur, remember how we fix a broken femur fracture. Then you get your patella, your kneecap, and then your fibula and your tibia, or your shin bone. And then kind of the same thing for your hands. You have your metacarpals and your phalanges. So phalanges is going to be at the end, and then you have metatarsals for your foot bones, and then your tarsals are going to be at the start. The foot consists of 3 classes of bones: your ankle bones, tarsals, foot bones, metatarsals, and toe bones, phalanges. And then your heel is called your calcaneus. And then you have your Achilles tendon back here, and then your tibia, your shin bone. The bones of the skeleton provide a framework to which the muscles and tendons are attached. A joint is formed wherever 2 bones come into contact, held together in a tough fibrous capsule, lubricated by synovial fluid, allow motion. Mechanism of injury. Significant force is generally required to cause fractures and dislocations. Direct blows, indirect forces, twisting forces, high energy forces. Fractures. Break in the continuity of the bone, classified as either closed or open. Determine whether the overlying skin is damaged. Treat any injury that breaks the skin as a possible open fracture. So fractures are described by whether the bone is moved from its normal position. A non-displaced fracture is a simple crack of the bone. A displaced fracture produces actual deformity or distortion of the limb, shortening, rotating, or angulating it. And then you have different types of fractures here. For some of the people that have broken bones. Comminuted fracture in which the bone is broken into more than 2 fragments. Epiphyseal, a fracture in the growth section of a child's bone. Green stick fracture is an incomplete fracture that passes only partway through the shaft of a bone. Incomplete, a fracture that does not run completely through the bone. Oblique, a fracture in which the bone is broken at an angle across the bone. Pathologic, a fracture of weakened or diseased bone. Spiral, fracture caused by a twisting force causing an oblique fracture around and through the bone. Transverse, a fracture that occurs straight across the bone. Okay, suspect a fracture. One of the more following signs are present: deformity, tenderness, guarding, swelling. Okay, so that looks like a possible tib-fib fracture. It's a deformity. Or it could also be a possible dislocation of the ankle. You're just going to relay that to the hospital that there's positive deformity. You're not going to call that a fracture because you don't have any confirmation on it when you're doing your PCR. Just visible deformity, and then put possible tib-fib fracture, possible ankle fracture. Signs of fractures: bruising, crepitus, false motion, exposed fragments, pain, locked joint. Dislocation. A dislocation is a disruption of a joint in which the bone ends are no longer in contact. Sometimes a dislocated joint will spontaneously reduce. Confirm the dislocation with the patient history. A dislocation that does not reduce is a serious problem. Signs and symptoms: marked deformity, swelling, pain that is aggravated by any attempt at movement, tenderness on palpation, loss of normal joint motion, numbness or impaired circulation. Sprain. A sprain occurs when a joint is twisted or stretched beyond its normal range of motion. Can range from mild to severe. Most vulnerable joints are the knees, shoulders, and ankles. Severe deformity does not typically occur. Signs and symptoms: guarding, swelling, ecchymosis, pain, instability of the joint. So I got some swelling here and some ecchymosis. Possible fracture. Depends on if you feel crepitus or breaking of the bone, cracking of the bone when you press down on that. Might just be a sprain. Might be a dislocation. Strain is a stretching or tearing of the muscle. Causes pain, swelling, and bruising of the soft tissues in the area. Often no deformity is present and only minor swelling is noted at the site of injury. Amputation. Amputation is an injury in which an extremity is completely severed from the body. Can damage every aspect of the musculoskeletal system. Complications. Orthopedic injuries can also lead to systemic changes or illnesses. Likelihood of having a complication is related to the strength of the force that caused injury, injury's location, patient's overall health. To prevent contamination following an open fracture, brush away any debris on the skin. Do not enter or probe the fracture site. Long-term disability is one of the most devastating consequences of an orthopedic injury. You can help reduce the risk or duration of long-term disability by preventing further injury, reducing the risk of wound infection. So this is why it's always good to, if you have any open wounds, they always say to clean it and continue to clean it until it's healed. You don't want to get infected. Minimizing pain by the use of cold and analgesia. So that'd be Tylenol or ibuprofen. And you also want to use cold packs or a bag of ice to keep the swelling down. Transport patients to an appropriate medical facility. Assessing the severity of the injury. The golden hour is critical for life and preserving limb viability. So remember, you have 60 minutes you're shooting for. When they talk about the golden hour, from the time the accident occurred to the time the patient gets to the hospital, is your golden hour, is the time you want to get that patient seen by a doctor. Prolonged hypoperfusion can cause significant damage. Any suspected open fracture or vascular injury is a critical emergency. Most injuries are not critical. Use a grading system. Patient assessment. Always look at the big picture. Distinguish mild injuries from severe injuries. Severe injuries may compromise neurovascular function, which could be limb-threatening. Scene size up, scene safety, identify the forces associated with the MOI. Standard precautions involve gloves, a mask, and a gown. Consider that there may be hidden bleeding. Evaluate the need for additional support. Mechanism of injury or MOI, nature of illness. Look for indicators of MOI. Be alert for both primary and secondary injuries. Consider what injuries the MOI would lead you to expect. Primary assessment. Focus on identifying and managing life threats. Treat patient according to level of consciousness and ABCs. Address bleeding and treat for shock. Check for responsiveness using the AVPU scale or ABPU scale. Ask about the chief complaint. Look for pertinent negatives. Look for pertinent positives. What is your index of suspicion telling you? Administer high flow oxygen to all patients whose level of consciousness is less than alert and oriented. Ask about MOI. If there is significant trauma, the musculoskeletal injuries may be a lower priority. Airway and breathing. Fractures and sprains usually do not create airway and breathing problems. Evaluate the chief complaint and MOI. Little else matters if the patient's airway and breathing are inadequate. Remember, the patient doesn't have an airway. Patient's dead. Nothing else matters. Circulation. Determine whether the patient has a pulse, has adequate perfusion, or is bleeding. If the skin is pale, cool, or clammy and capillary refill time is slow, treat for shock. Maintain a normal body temperature. Transport decision. Provide rapid transport if the patient has an airway or breathing problem or significant bleeding. A patient who has a significant MOI but whose condition appears stable should also be transported promptly. Patients with a simple MOI may be further assessed on scene. History taking. Obtain a medical history and be alert for injuries to specific signs and symptoms and any pertinent negatives. Remember, everyone gets a sample, no matter if it's medical or trauma. Obtain a sample history for all trauma patients. OPQRST is too lengthy when ABCs require immediate attention. If the patient's altered or unresponsive, you're not going to get OPQRST. Just treat injuries as you see them, get vital signs, and try and get a sample history and transport to the hospital. Get them to the hospital within that golden hour. Secondary assessment, physical examinations. If significant trauma has occurred, start with the secondary assessment of the entire body. Begin with the head and work systemically toward the feet. Use DCAP BTLS to assess the musculoskeletal system. When lacerations are present in an extremity, consider an open fracture. Any injury or deformity of the bone may be associated with vessel or nerve injury. Assess neurovascular function. Use the 6 P's of musculoskeletal assessment. Vital signs. Determine a baseline set of vital signs: pulse rate, rhythm and quality, respiratory rate, rhythm and quality, blood pressure, skin condition, pupil size, and reaction to light. So remember, on every patient, you're going to at least get a pulse rate, a respiratory rate, or blood pressure. You also want to get a skin condition if possible. You could tell just by looking at a patient. Do they look pale? Do they look flushed? Does their skin look normal? You could also ask family members. Does their skin normally look like that? Do they normally look pale? Do they normally look a little flushed? Repeat the primary assessment every 5 minutes for an unstable patient, every 15 minutes for a stable patient. Assess the overall condition, stabilize the ABCs, and control any serious bleeding. In a critically injured patient, secure the patient to a long backboard and transport. If a patient has multiple fractures and they're in a serious trauma, go ahead and secure them to a long backboard. And if you have time, you could stabilize those fractures en route to the hospital. It's more vital that they get on a long backboard than going and splinting multiple fractures. That's going to take a lot more time on scene, and that patient needs to get to the hospital. If a patient has no life-threatening injuries, take extra time at the scene to stabilize his or her condition. The main goal is stabilization in the most comfortable position that allows for maintenance of good circulation distal to the injury. Communication documentation included description of the problems found during your assessment. So when you guys are writing your PCRs, note the mechanism, note what happened, and try and be descriptive as possible. And then note any injuries found, and also note any pertinent negatives and pertinent positives. Report problems with the ABCs, open fractures, and compromised circulation. Document complete descriptions of injuries and MOIs associated with them. Emergency medical care. Perform a primary assessment. Stabilize the patient's ABCs. Perform a secondary assessment of either the entire body or a specific area of injury. Follow standard precautions. Be alert for internal bleeding. Splinting. A splint is a flexible or a rigid device that is used to protect and maintain the position of an injured extremity. So splint all fractures, dislocations, and sprains before moving the patient, unless he or she is in immediate danger. So this can be an emergency move. Splinting reduces pain and makes it easier to transfer and transport the patient. Splinting will help prevent further damage to muscles, the spinal cord, peripheral nerves, and blood vessels, laceration of the skin, restriction of distal blood flow, excessive bleeding of the tissues, increased pain, paralysis of extremities. General principles of splinting: remove clothing from the area, note and record the patient's neurovascular status, cover open wounds with a dry, sterile dressing, do not move the patient before splinting an extremity unless there is danger, stabilize the joints, pad all rigid splints, maintain manual stabilization. If you encounter resistance, split the limb in its deformed position, immobilize all suspected spinal injuries in a neutral inline position. When in doubt, splint. So rigid splints made from firm material apply to the sides, front, and or back of an injured extremity, prevent motion at the injury site. Take 2 EMTs to apply. 2 situations in which you must splint the limb in a position of deformity: when the deformity is severe, when you encounter resistance or extreme pain when applying gentle traction to the fracture of a shaft of a long bone. So only try and reposition a deformity once. If you're unable to fix the deformity after you try and replace it, just splint it in the position that it's in. Formable splints. Most commonly used formable splint is a pre-contoured inflatable clear plastic air splint. Comfortable, provides uniform contact, applies firm pressure to a bleeding wound. Used to stabilize injuries below the elbow or knee. Drawbacks: the zipper can stick, clog with dirt, or freeze. Significant changes in the weather or altitude affect the pressure of the air in the splint. Other formable splints have vacuum splints, pillow splints, structural aluminum malleable splints or SAM splints, sling and swath, pelvic binder. Traction splints: acts of pulling on a body structure in the direction of its normal alignment. Used primarily to secure fractures of the femur. Goals of inline traction: to stabilize the fractured fragments, to align the limb sufficiently to avoid potential neurovascular compromise. Do not use for any of these conditions. traction splint. Injuries of the upper extremity, injuries close to or involving the knee, injuries of the pelvis, partial amputations or avulsions with bone separation, lower leg, foot, or ankle injury. Imagine where the uninjured limb would lie and pull gently along the line of that imaginary limb until the injured limb is in approximately that position. Okay, so we have a midline femur fracture. You want to hold manual stabilization like this this EMT is doing right now. Trying to realign it down here so it's straight. And then we're going to go ahead and measure our traction splint and go ahead and apply that. So pelvic binder, used to splint the bony pelvis to reduce hemorrhage from bone ends, venous disruption, and pain. Meant to provide temporary stabilization, should be light, made of soft material, easily applied by one person, and should allow access to the abdomen, perineum, anus, and groin. Hazards of improper splinting, compressions of the nerves, tissues, and blood vessels, delay in transport of a patient with a life-threatening injury, reduction of distal circulation, aggravation of the injury, injury to tissue, nerves, blood vessels, or muscles. Transportation. Very few musculoskeletal injuries justify the use of excessive speed during transport. A patient with a pulseless limb must be given a higher priority. If the treatment facility is an hour or more away, transport by helicopter or immediate ground transportation. Injuries of the clavicle and scapula. The clavicle is one of the most commonly fractured bones in the body. Occur commonly in children. A patient will report pain in the shoulder and hold the arm across the front of the body. Swelling and point tenderness occur over the clavicle. Fractures of the scapula occur much less frequently because the bone is well protected by many large muscles. Almost always the result of a forceful direct blow to the back. The associated chest injuries pose the greatest threat of long-term disability. Acromyoclavicular joint is frequently separated during sports. These fractures can be splinted effectively with a sling and swath. So any type of shoulder injury, clavicle injury, you could go ahead and use your triangle bandage. Okay, so he's got the triangle bandage on, the sling, and then now she's applying the swath. So it just comes around the back and to the front to make sure that patient's arm doesn't move around. It stays right up against his chest. Dislocation of the shoulder. The humeral head most commonly dislocates anteriorly. Shoulder dislocations are very painful. Stabilization is difficult because any attempt to bring the arm in toward the chest wall produces pain. Splint the joint in whatever position is more comfortable for the patient. Remember, transport patients in a position of comfort. If the patient's injured, try and put them in a position of comfort, especially in shoulder injuries or any type of traumatic injuries. Fracture of the humerus occur either proximally in the midshaft or distally at the elbow. Consider applying traction to realign the fracture fragments before splinting them. Splint the arm with a sling and swath. Elbow injuries. Different types of injuries are difficult to extinguish without X-ray examinations. Fracture of the distal humerus, common in children. Fracture fragments rotate significantly, producing deformity and causing injuries to nearby vessels and nerves. Dislocation of the elbow typically occurs in athletes. The ulna and radius are most often displaced posteriorly. So you have your dislocation of an elbow. You're going to try and remember what's the first thing you're going to do for any deformity. You're going to try it. You're going to stabilize, manually stabilize the elbow. Check for CSM, and then see if you could put it in a position of comfort or try and realign it. And then if you happen to splint this, you're going to go ahead and recheck CSM. Elbow joint sprain, often mistakenly applied to an occult non-displaced fracture. Fracture of olecranian process of ulna can result from direct or indirect forces. Often associated with lacerations and abrasions. Patient will be unable to extend the elbow. Fractures of the radial head. Often missed during diagnosis. Generally occurs as a result of a fall on an outstretched arm or direct blow to the lateral aspect of the elbow. Attempts to rotate the elbow risk cause discomfort. Care of elbow injuries. All elbow injuries are potentially serious and require careful management. Always assess distal neurovascular functions periodically. Provide prompt transport for all patients with impaired distal circulation. Fractures of the forearm. Common in people of all age groups. Seen most often in children and elderly. Usually the radius and ulna break at the same time. Fractures of the distal radius are also known as Colles fractures. To stabilize fractures, you can use a padded board, air vacuum, or pillow splint. Injuries of the wrist and hand must be confirmed by x-ray exams. Dislocations are usually associated with a fracture. Isolated, non-displaced fracture of a carpal bone is common. Any questionable wrist injuries should be splinted and evaluated in the ED. Fractures of the pelvis often result from direct compression in the form of a heavy blow. Can be caused by indirect forces. Not all pelvis fractures result from trauma. May be accompanied by life-threatening loss of blood. Open fractures are quite uncommon. Suspect a fracture of the pelvis in any patient who has sustained a high-velocity injury and complains of discomfort in the lower back or abdomen. Assess for tenderness. Injury to the bladder or the urethra may cause lower abdominal tenderness and evidence of hematuria or blood. So any motorcycle accident, this happens to a lot of people who get in motorcycle accidents. They're going to fracture their pelvis. This is a life-threatening emergency. They could bleed out. Okay, so remember how you're assessing the pelvis. You're going to push down and in so you can feel the iliac crest. Okay, and then you could also push down on the groin area, the pubic symphysis, to make sure the pelvis isn't broken or if you feel any crepitus. Dislocation of the hip dislocates only after significant injury. Most dislocations are posterior. Suspect a dislocation in any patient who has been in an automobile crash and has a contusion, laceration, or obvious fracture in the knee region. Posterior dislocation is frequently complicated by injury to the sciatic nerve. Distinctive signs: severe pain in the hip, strong resistance to movement of the joint, tenderness on palpation. Do not attempt to reduce a dislocated hip in the field. Splint the dislocation. Place the patient supine on backboard. Support the affected limb with pillows. Secure the entire limb to the backboard with long straps. Provide prompt transport. Fractures of the proximal femur. Common fractures, especially in older people and patients with osteoporosis. Break goes through the neck of the femur, the inner canteric region, or across the proximal shaft of the femur. Patients display characteristic deformity. Lie with the leg externally rotated, and injured limb is usually shorter than the opposite uninjured limb. So remember, if anybody's complaining of leg pain or hip pain, you want to make sure to straighten their legs out. See if one's longer than the other, or one's shortened and rotated, and how that leg is positioned, the injured leg. Assess the pelvis for any soft tissue injury and bandage appropriately. Assess pulses and motor and sensory functions. Splint the lower extremity and transport to the emergency department. Femoral shaft fractures can occur in any part of the shaft, from the hip region to the femoral condyles, just above the knee joint. Large muscles of the thigh spasm in an attempt to splint the unstable limb produces significant deformity and shortened limb. There is often significant blood loss. Bone fragments may penetrate or press on important nerves and vessels. Carefully and periodically assess the distal neurovascular function. Cover any wound with a dry, sterile dressing. These fractures are best stabilized with a traction splint. So any mid-femur fracture that's closed, you're going to try and do a traction splint. Injuries of knee ligaments. Many different types of injuries occur in this region. Ligament injuries, dislocated patella, bony elements can fracture. With ligament injuries, you will generally find swelling, occasional ecchymosis, point tenderness at the injury site, a joint effusion. Splint all suspected knee ligament injuries. Dislocation of the knee. These are true emergencies that may threaten the limb. Ligaments may be damaged or torn. You have an artery right behind your knee. This could possibly be torn. You could bleed out. Direction of dislocation refers to the position of the tibia with respect to the femur. Posterior dislocations and medial dislocations. Complications may include limb-threatening popliteal artery disruptions. Remember, the artery right behind your knee is called the popliteal. Injuries to the nerves, joint instability. If adequate distal pulses are present, splint the knee and transport promptly. Fractures about the knee may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella, the actual kneecap. If there is an adequate distal pulse and no significant deformity, splint the limb with the knee straight. If there is an adequate pulse and significant deformity, splint the joint in the position of the deformity. The pulse is absent below the level of injury. Contact medical control. Let them know what's going on. See if you could realign it. See if that'll get your pulses back or your CSM back. And if it doesn't, you can contact medical control and ask them if you want to try and realign it again or just come and code through to the hospital. Never use a traction splint on a knee injury. You're going to make the injury worse and possibly more damage to the ligaments or the bones. Dislocation of the patella most commonly occurs in teenagers and younger adults in athletic activities. Usually the dislocated patella displaces to the lateral side and produces significant deformity. Splint the knee in the position in which you find it. Injuries of the tibia and fibula. Fracture may occur at any place between the knee joint and the ankle joint. Often both bones fracture at the same time. Stabilize with a padded, rigid, long leg splint or an air splint. Correct severe deformity with a gentle longitudinal traction. Ankle injuries. The ankle is a commonly injured joint. Range from simple sprains to severe fracture dislocations. Any ankle injury that produces pain, swelling, localized tenderness, or the inability to bear weight must be evaluated by a physician. Management. Dress all open wounds. Assess distal neurovascular function. Correct any gross deformity by applying traction. Before releasing traction, apply a splint. Foot injuries can result in the dislocation or fracture of one or more of the tarsals, metatarsals, or phalanges of the toes. Frequently, the force of injury is transmitted up the legs to the spine. So you see this patient's jumping off a little wall. He's landing on his feet. All that force is going all the way back up his spine, all the way up his hips into the lower part of his spine. If you suspect a foot dislocation, assess for pulses, motor, and sensory function. Injuries of the foot are associated with significant swelling, but rarely with gross deformity. To splint with the foot, apply a rigid padded boarded splint, an air splint, or a pillow splint. Leave the toes exposed. This way you could check CSM. Strains and sprains. General treatment is similar to that of fractures. Rice, mnemonic. Rest, ice, compression, elevation, and splinting. So for any of you who have sprained an ankle, you probably use the Rice method. You probably sat on the couch, put a couple pillows under your ankle, and thrown some ice on there to keep the swelling down. Amputations. Surgeons can occasionally reattach amputated parts. Make sure to immobilize the part with bulky compression dressing. Do not sever any partial amputations. Try and keep that limb still on if it is. Control any bleeding from the stump. If bleeding is severe, quickly apply a tourniquet. With a complete amputation, wrap the clean part in a sterile dressing and place it in a plastic bag. Follow local protocols regarding how to preserve amputated parts. Put the bag in a cool container filled with ice. Do not put the amputated part directly on ice. The goal is to keep the part cool without allowing it to freeze or develop frostbite. If you put it directly on ice, it will freeze and it will develop frostbite, and then you potentially lost the possibility of having that limb reattached. Compartment syndrome most often occurs with a fractured tibia or forearm of children. Typically develops within 6 to 12 hours after injury as a result of excessive bleeding, a severely crushed extremity, the rapid return of blood to an ischemic limb. Characterized by pain that is out of proportion to the injury, pain on passive stretching of muscles within the compartment, pallor, decreased sensation, decreased power. If you have a pediatric patient with a fracture below the elbow or knee, be on the lookout for these signs and symptoms: extreme pain, decreased pain sensation, pain on stretching of affected muscles, decreased power. If you suspect the patient has compartment syndrome, splint the affected limb, keeping it at the level of the heart. Transport immediately. Reassess neurovascular status frequently during transport. So review, skeletal muscle is also referred to as what? How many different types of muscle do you guys have? So B, skeletal muscle, also called striated muscle because of its characteristic stripes, striations, attaches to the bones and usually crosses at least one joint, forming the major muscle mass of the body. This type of muscle is also called voluntary muscle because it is under direct voluntary control of the brain. You respond to a soccer game for a 16-year-old male with severe ankle pain. When you deliver him to the hospital, a physician tells you that he suspects a sprain. This means that So C, a sprain is a joint injury in which there is both partial or temporary dislocation of the bone ends and partial stretching or tearing of the supporting ligaments. Sprains are typically marked by swelling, pain, and ecchymosis. A young male has a musculoskeletal injury and is unresponsive. You will not be able to assess Remember, you're checking CSM when you're splinting. What can you not check when you're doing CSM? The purpose of splinting a fracture is to B. The purpose of splinting fractures is to prevent motion of the bony fragments, thus minimizing the possibility of neurovascular damage. Splinting is not intended to force bony fragments into anatomic alignment, nor will it reduce swelling. Ice reduces swelling. You should never try to reduce a fracture. Motorcyclist crashed his bike and has closed deformities to both of his midshaft femurs. He is conscious but restless. His skin is cool and clammy, and his radial pulses are rapid and weak. Most appropriate splinting technique for the patient involves this is a multi-system trauma, so it's more important. C, in this particular case, it is more practical and less time-consuming to secure the patient to a long backboard. He is in shock and requires rapid transport. Taking the time to apply traction splints, air splints, or board splints will only delay transport. If you have time in the back of an ambulance, you could try and use traction splints on his femurs, depending on how long your transport time is, or if you have time to do that. In this case, it's probably better to get him to the hospital as quick as possible and not delay any time on scene to put him in traction splints. To effectively immobilize a fractured clavicle, you should apply a A, the quickest and most effective way to immobilize a fractured clavicle or collarbone is to apply a sling and swath. The sling will help minimize the movement of the clavicle itself, while the swath will minimize movement of the arm on the affected side. A patient tripped, fell, and landed on her elbow. She is in severe pain and has obvious deformity to her elbow. You should B. When caring for a patient with an orthopedic injury, you should first manually stabilize the injury site. This will prevent further injury. You should then assess pulse, motor functions, and sensory functions distal to the injury. Splint the injury using the appropriate technique and then reassess pulse, motor functions, and sensory functions. Do not intentionally assess for crepitus. This is a coincidental finding that you may encounter during your assessment and should not be elicited. When treating an open extremity fracture, you should So B, prior to splinting an open extremity fracture, you should cover the wound with a dry, sterile dressing. This will help control any bleeding and decreases the risk of infection. Irrigating an open fracture should be avoided in the field. This also increases the risk of infection, especially if foreign material is flushed into the wound. Which of the following musculoskeletal injuries has the greatest risk for shock due to blood loss? So A, the pelvic cavity can accommodate a large volume of blood. Shock in a patient with a pelvic injury is usually due to injury to femoral veins or arteries. Bilateral femur fractures can also cause severe blood loss, up to 1 liter per femur. So femur fractures and pelvic fractures, you guys have to really be worried about and have a high index of suspicion. People could bleed out and die from these injuries. Patient injured her knee while riding a bicycle. She is lying on the ground, has her left leg flexed, is in severe pain, and cannot move her leg. Your assessment reveals obvious deformity to her left knee. Distal pulses are present and strong. The most appropriate treatment for her injury involves So B, the patient likely has a dislocated knee. You should immobilize any joint injury in the position in which it was found, especially if distal pulses are present and strong. Attempting to straighten or load a dislocated joint may cause damage to the nerves and or vasculature.